I welcome all of you to this pink city of Jaipur. Hope all of you are having good time. And I also thank AIOS for giving us this opportunity to share our insights on this topic of eco in difficult situations with you all. So without taking any further time, I'll start the talk. Just to give a brief introduction of the topic, so we will be talking on mastering phacoemulsification in difficult eyes. I don't have any financial disclosure, none of us. So the topics that we will be covering are non-ophthalmic eyes by Dr. Prakhyat Roop, vitrectomized eyes, I will be covering that. High myopic eyes, Dr. Saurabh Bhargav, and high hypermetropic eyes, Dr. Tanveer Alam Khan. Phacoemulsification is the most common cataract surgery technique, as we all know, and certain ocular conditions present unique intraoperative challenges. Proper surgical planning and technique modification are essential to achieve good outcomes. So this presentation highlights key considerations in difficult cases. So it will be more of a video based, we'll be presenting some of the theory and the videos. Coming to vitrectomized eyes, the challenges are deep unstable anterior chamber, lack of vitreous support, floppy posterior capsule, totally different scenario in silicone oil filled eyes. We'll be covering that in detail. And the key considerations that we'll be discussing are IOL power calculation in silicone oil filled eyes, lower infusion pressure, stable chamber maintenance, gentle nucleus emulsification, and post-op PC plaque. High myopic eyes, the challenges are deep anterior chamber, large capsular bag, larger axial length, which challenges us in calculating the IOL power, weak zonules, incidence of LIDRS, and increased risk of posterior capsular rupture. So the points that we'll be covering are careful hydrodissection, controlled phaco power, and appropriate IOL selection and IOL power calculation. In high hyperopic eyes, the challenges are, as we all know, shallow anterior chamber, small capsular bag, increased risk of corneal endothelial damage. The points that will be covering up are adequate viscoelastic use, which visco to be used, gentle nucleus manipulation, and precise IOL power calculation. And then last not the least, non-ophthalmic eyes, extremely short axial length, shallow anterior chamber, risk of uveal effusion, and very hard cataracts in most of the cases. So preoperative planning, use of high viscosity OVD, and slow and controlled surgical maneuvers are the most important thing. So I now invite upon Dr. Prakhyat to come over. इसी पे आएगा क्या? लिखना होता है सर? नहीं उस वो जाएगा ना, उस पे स्विच कर दो ना.
Very good morning to everyone, and I thank the organizing team and Dr. Khungar for giving me this opportunity. I am Dr. Prakhyat Roop, and I'll be talking about phacoemulsification in nanophthalmic eyes. So, first of all, before we jump into nanophthalmos, actually in consideration are the anatomical eye types and the understanding that not all short eyes are the same. Jack Holliday actually worked while he was working on his IOL formula, power calculation formula. He actually worked out the different types of small eyes that can be in terms of the anterior segment versus the total axial length configuration. And he found that actually it was only 20% of the short eyes that were actually nanophthalmic. For our purpose, for our interest, we are going to talk about the relative anterior microphthalmos, which means that there is a normal axial length, but the anterior segment is small, and since the anterior segment is the place where we are going to do the phaco, so that is of concern to us as well. Apart from nanophthalmos, which is obviously short anterior segment along with a small axial length. In the phenotypes of small eyes, we must make the distinction between nanophthalmos, microphthalmos, and relative anterior microphthalmos. So in relative anterior microphthalmos, there is only crowded anterior segment, and rest everything is going to be normal, including the biometry and the IOL power that you're going to put. In microphthalmos, it's actually a structural or a developmental anomaly that is commonly present. For example, an iridofundal coloboma or a persistent pupillary membrane, persistent fetal vasculature, or something like that. And they have a short anterior segment along with a short axial length. Nanophthalmos are anatomically normal eyes. Developmentally also they are normal eyes, but they have a significantly short axial length and a crowded anterior segment. And uveal effusion risks are high in nanophthalmic eyes because of high scleral rigidity. But that's not really a concern while doing a phacoemulsification. It's more of a preoperative consideration. So before, just to put things into perspective, have a look at this video where it's not playing. Sorry. Yeah. So this is one of my cases during my residency, and I'm following more or less the standard guidelines. You know, you make a scleral tunnel, you make a posterior limbal incision. I am doing a rhexis in a fibrosed capsule. I can't complete it, so I trim it with a micro scissor, create a complete rhexis, and then I go ahead moving on its own. अपने आप चल रहा है, मैं तो कोई बटन नहीं है, छोड़. So I go ahead and I put my iris hooks and everything, and I go ahead with doing the phacoemulsification part in this case. The axial length is small, but the lens thickness is very, very high. So I keep doing a deep and deep trench in a very stony hard nucleus where there is no epinucleus. Practically it's all hard nucleus in toto, and I am going deeper and deeper, having injected OVD, trying to make chops that go to the posterior plate, but I fail miserably. Then I try to flip the posterior plate and actually realize that there is a zonular dialysis. So I decide that I should deliver and not cause any more harm. And that's how this surgery ended, with this person being aphakic without a capsular bag. And I later had to do a scleral fixation with a endothelial keratoplasty. So this is basically the challenge in doing such a surgery. Shallow AC gives you a reduced working space, higher risk of endothelial damage, and difficult maneuverability. You can't do all the flips and all the things that you could do in a normal anterior segment. Endothelial vulnerability comes in because there's already some endothelial damage or dropouts because of a shallow anterior chamber, a crowded anterior chamber that the patient has had for a long time, and they also have hard cataracts. So you have a lesser reserve and you're going to cause more damage anyway. Zonular abnormalities are common with anteriorly inserted zonules. The cursor is moving on its own. With anteriorly inserted zonules and weak zonular support, there is a risk of uveal effusion, but that is, again, like I said, you have to evaluate preoperatively, and if it's okay, you have to go ahead with your surgery. And then there are challenges in IOL power calculation. You may have to resort to a piggyback approach if you can't get the right power of IOL or come close to it. So preoperatively, the key biometric parameters would be the axial length. Optical biometry is always preferable. You can confirm by two methods. AC depth, you must determine the intraoperative working space and be prepared accordingly. Lens thickness, because lens can be difficult to split, the corneal white to white gives you a false perspective, and at that time you may feel even a normal lens thickness feels to be really deeper. And white to white, again, to anticipate the AC volume and your space for doing the maneuvers, and specular count, because it is often low in these cases. The other risk assessment of angle closure and the risk of choroidal effusion should be assessed. Visual potential and amblyopia are common, so visual potential should be assessed. The preferred formula nowadays is Barrett's Universal 2, better than Holiday 2 and Haigis. So, as I passed in my career, I started doing more and more such kind of cases. So I now coat the endothelium thoroughly with a dispersive OVD, make again a scleral tunnel, and through that my main incision. And this time I don't do all the flipping and zonular stressing maneuvers, and I am able to complete my surgery comfortably in a type 1 IFC where the red glow is also not in my favor. And you can see the bluish tinge because the dye has gone posteriorly, and that is common to happen in these cases. And when you gain more experience, and depending on individual eye, you can also actually get away without any iris hooks and maintaining a very crystal clear cornea till the very end of surgery. And that is basically just to show that it's a whole spectrum of your surgical expertise and the configuration of the eyes that can decide which approach you are going to take. In the surgical approach, what always works in nanophthalmic eyes is an optional pre-operative decrease in the vitreous pressure, so you can give mannitol beforehand. A scleral tunnel or a posterior incision is always helpful because it keeps your phacoprobe away from the endothelium and causes less endothelial damage. Use of pupil expansion devices such as iris hooks. Iris hooks is my preferred choice because I can customize the amount of pull or the dilatation that I am going to make in the pupil. The B-hex ring is also a good alternative, but it is difficult sometimes when there is very shallow anterior chamber, although it adds the advantage of easier manipulation of globe if you generally move your globe from the primary position while doing phaco. Malugan ring is a strict no-no for me because it's quite bulky and I have never been able to successfully use it in such an eye. Adequate OVD, dispersive OVD replenishment is essential and should be done frequently. An adequate or larger rhexis, the significance of this cannot be overemphasized because, again, because of the smaller white to white, you get the perspective that your rhexis is quite large. But understand that the lens and its equator is as bulky and as big as in a normal eye. Only you are seeing it through a much smaller window of clear cornea. So your rhexis actually should intuitively feel to be larger than what you generally make. And now that leaves us with one challenge, which is managing the hard nucleus with zonular weakness in a limited space. And to that, I have this technique which was devised by my father in the year 2008. It is called the circumferential chop. These days, it's also known as stratified phaco, being popularized by Dr. Rohit Om Prakash. And it basically addresses all the problems of zonulopathy with a suprahard cataract and less AC depth, and allows you to safely execute your phacoemulsification in the limited space. So the steps of this surgery are that first, you de-roof the anterior epinuclear plate, and next, you go ahead with producing peripheral chops that don't advance to the posterior center. So you don't do a aggressive lateral separation, but you only do peripheral chops that don't go till the center. This generally will reveal an endonuclear core that you can emulsify in situ, that creates a central space where you can delaminate these sectors inward and use that space to complete your phaco. So here you can see this being demonstrated. I am not going ahead with advancing the peripheral chops or doing a lot of lateral separation because the bag is lax, the zonules are weak, and the cataract is hard. So I only do these peripheral chops, kind of like opening the petals of a flower. And then in the center you see the thickest or the densest endonuclear core is actually exposed. And you emulsify this in situ within the cushion of all the nuclear material that is remaining in the surrounding areas. And once you've done that, then you delaminate each sector of these petals that you have made. You don't actually take them completely in one go, but you actually circumferentially delaminate them from the inside to the outside. You can also try to deepen the trench if you use torsional phaco. Then it's a good maneuver to do that. You can actually deepen your trench, and that allows you to be able to easily create the crack in the posterior plate while holding the nuclear material at the anterior subcapsular area. And that is how you can actually crumple each sector towards the center of the capsular bag and keep emulsifying all of the nucleus. So the rationale behind this technique, and this is probably the only addition that I can suggest to the generally understood dictums of managing nanophthalmic eyes, is this technique where basically you make a deroofing in the anterior epinucleus, then you make peripheral cracks only. Don't try to take them to the posterior plate. Emulsify the cleaved endonucleus. Then, taking the inner lamellae of each remaining sector, you emulsify only the inner lamellae by actually moving your chopper in a tangential manner and emulsify the emptied central space. Optionally, you can deepen the posterior plate trench later and then completely dismantle each sector of the outer nucleus. So circumferential chop, scleral tunnel, and frequent refilling of dispersive OVD. Thank you.
Very nicely covered, Dr. Prakhyat. Actually, Dr. Prakhyat has to leave for another session, so we can have questions for him now itself. If there are any questions, though he has covered the circumferential chop in a very nice manner. Congratulations to you, Dr. Prakhyat.
Thank you, sir.
So if we don't
Thank
have
you.
any questions, any questions? Okay, so if we don't have any questions, I'll go to the second. So I'll be talking on phaco in vitrectomized eyes. No financial disclosure. So when we are operating on a vitrectomized eyes, pre-operatively we have to sit down, we have to think what is different in this eye and what planning we have to do pre-operatively. I'll be covering that first. So we know that vitrectomized eyes need special considerations as they manifest altered behavior. What altered behavior we'll be covering that. This is due to the previous surgery or the underlying pathology which led us to a VR surgery. So in anticipation of the difficulties I had, we have to modify our surgical techniques and we have to achieve a successful surgical outcome so that our patients attain a good vision. So the history of past surgery is very important. Whether it is a limited vitrectomy or an extensive complete vitrectomy, then that decides how we have to go about it. And third point is whether it is a silicone oil filled eye or not. Because if it is a silicone oil filled eye, it will have shallow chambers pre-op, per-op, and without oil have deep fluttery chambers. Both are different. So our planning remains different. Then comes to coming to IOL power calculation, though we know that the newer biometers have formulas for silicon oil, because we have to learn this, we have to know this, understand this, that the speed of sound is very slow in silicon oil. In older biometers, we have to multiply the axial length by 0.64 to get the true axial length, because the specific gravity of vitreous oblique specific gravity of silicon oil is 0.982 by 1.532. And we have to prefer optical biometers, especially swept source OCT based, if we have access to that. Then slit lamp examination, rule out zonular dialysis as silicon oil has degenerative effects on the zonules. There can be a pre-existing posterior capsular defect, as PC may have been damaged by vitrectomy probe accidentally. So this can present as sudden formation of mature cataract. If there is a sudden formation of mature cataract after VR surgery, we have to keep this in mind. Then PC plaque. This may not be able to be removed simply by scraping or vacuum cleaning during surgery. So YAG laser may be needed, but do it only after 6 weeks and make small opening to avoid silicone oil spillage. Inform about surgical difficulties. We have to counsel the patient about the zonular dialysis, PC defect, pre-existing PC defect which may be present. IOL options need to be discussed, and patient has to be told that we may have to change a 1-piece IOL to a 3-piece IOL on the table. And about PC plaque, that the visual acuity may not be regained fully, so we may have to do a laser later on. Coming to surgical strategy, as far as anesthesia is concerned, avoid topical and intracameral, as intracameral may permeate through weak degenerated zonules and may cause retinal toxicity. As we say that if there is a posterior capsular rupture, don't inject intracameral xylocaine, because that is going to directly have a retinal toxicity. So only topical is painful due to chamber fluctuations. Peribulbar is of choice. Avoid massage or pressure to avoid zonular damage and hypotony. Coming to incisions and rexes, low ocular rigidity may cause difficulty in making corneal tunnel. So inject viscoelastic thoroughly through side port. Prefer larger rexes to avoid capsular phimosis, so that in post-op period examining the retina remains easy. Use of forceps causes lesser stress on zonules, but depends on individual choices. But if there is a PC defect anticipated, make a normal size rexes to implant a ciliary sulcus IOL. You may be needing the support of intercapsule here. Hydrodissection and rotation, gentle multi-quadrant hydrodissection. I'll be just coming to that in the video. Keep on decompressing nucleus in between multi-quadrant hydrodissection. No hydrodissection in mature cataract in case of suspected PC defect. And proper rotation must, as zonules are stretched and weak. So this is what is happening in vitrectomized eyes with and without silicone oil. There is a deepness in vitrectomized eyes without oil, and with oil there is a upthrust. And this is the plaque that I was talking about. Nucleus removal, eyes with extensive vitrectomy with no silicone oil, deep AC with flutter, use Kalman tip, low bottle height and lower parameters. Avoid overfilling with visco. While sculpting, use higher power to avoid zonular stretch. PC fluttering can cause its suction in the phaco probe. Beware of that. And with silicone oil, ideal is to remove, but various studies have shown the incidence of recurrent RD 17 to 30% after silicone oil removal. So we may have to go ahead with silicone oil in the eye. The main problem is forward push of the lens diaphragm, shallow AC, more in supine position, and higher bottle height and tight valvular incision. IOL biocompatibility is a must. So as blood aqueous barrier is compromised, higher uveitis rate. So prefer a hydrophobic IOL only, and never put a silicone IOL if you have a silicone oil in the eye, because oil adheres irreversibly to the back of the IOL. Wound closure, due to low scleral rigidity, wound integrity needs to be strengthened by suture many times. So in this video I'll be showing that how we make a larger axis here, and other steps we'll be showing. during rhexis there is no stretch on the zonules. So this I am just seeing that my nucleus is rotating freely. If I don't do this step, I can cause zonular dehiscence if the nucleus has not rotated fully. So then going to phaco, as I have already said, that we have to make a deeper trench here and use a higher power phaco here during sculpting. The chatter you can see is there because these cataracts are usually hard, especially this is a silicone oil filled eye. So the chopping has to be gentle. Don't try to go make the two pieces too much apart because the zonules are weak. Then you go 180-degree opposite, and going 180-degree opposite, once you have two hemispheres, the things become very simple. And then we now divide the two hemispheres into 3 to 4 pieces each, and then we consume these pieces. Again, I am using a Centurion intelligent phaco mode here so that I am not causing much of the stress in the bag. Then I am feeding these nucleus pieces with my chopper in the phaco probe to decrease the phaco energy, because we have a shallow interchamber in which we are working, so we have to save our endothelium. So once we have done with this, you can see the glistening. This glistening is typically in cases of silicone oil filled eyes. So once the cortical matter is removed, we can see that the plaque I showed in the picture is there. It becomes very difficult for us to remove this plaque, so better leave it there. Don't fiddle around with this. Don't try that our patient in day 1 or day 2 should have good 6x6 vision. There's another similar video, I'll skip that. This is another video in which there is no silicone oil. So you can see, I'll just show you the moment phaco probe goes inside, there is a sudden deepening of the anterior chamber, something that occurs in allied ears in high myopic eyes. So now the moment I'll enter inside, you can see that the nucleus and everything has gone down. So this is important. Thank you. Now I invite upon Dr. Saurabh Bhargav for his talk.
So wonderful. Just a question.
Yeah.
So wonderful coverage of patients with vitrectomized eyes. Like I just saw, you pointed out that intracameral xylocaine or oculan, whatever is used, might percolate through the loose zonules in such cases and cause
through the degenerated zonules, right? Because the silicone oil has a degenerative effect on the zonules.
So my question was, many of these vitrectomized patients are high myopes. They must have had an RD, and an RD surgery must be done. Now, in such cases with the thinner sclera and the globe filling the entire orbit, do you recommend a peribulbar, or would you continue with what you just said?
A peribulbar given by the surgeon himself after seeing what is the axial length, rather than leaving it on your assistant to give the block. So that is one important part. But in case it is a vitrectomized eye where there is no silicone oil used, there you can go ahead with topical surgery, because there you can use intracameral. Thank you.
Thank you, AOS and Dr. Khungar, for giving me this opportunity. I'll be talking about phacoemulsification in high myopic eyes. Now, basically we need to understand is that in the current scenario, myopic patients and myopic cataract surgery is increasing. And our emphasis on this topic is because myopia, a myopic eye is not just a long eye. It's a biomechanically unstable eye. So, as we commonly encounter cases where the axial length is greater than 26 millimeters, or extreme myopia where the axial length is more than 30 millimeters. And we all know the altered biomechanics like the large bag, the incidence of posterior cephaloma, weak zonules, liquefied vitreous. All these are add-on part of our surgery which we need to take care of. Obviously, we need to have a thorough examination of the retina by our retinal colleague, and only then that green flag when it is given, we can go ahead with the surgery. Now, optical biometry, though is the gold standard, one should repeat it, preferably with another optical biometer, or if you have the swept source technology, then optical biometer of that quality is a must. Modern IOL formulas like Barrett Universal 2 are the ones which give you better accuracy. The modern formulas for myopia will give you an accuracy in the range of 0.3 millimeters, 0.3 diopters. So they should be used rather than the older formula. Obviously, OCT is a must for all case, especially the macula, and a peripheral retinal screening. Here, this is the fundus photo showing a lot of changes, as we all know, that are common with myopics. A B scan should also be done so that you might discover a cephaloma which was missed otherwise. OCT, as I just said, is important. The RNFL also is bizarre in myopics. It doesn't follow the characteristic hump pattern because of the thinning of the RNFL. But it's stable, so it's not basically, it can be differentiated from glaucoma. Here, what I need to emphasize is, this is a case, a young lady having an axial length of about 29.6 millimeters. And here, I've put two different biometries side by side to emphasize that though SRKT is accurate, you need to have the Barrett Universal 2. So here, the power was coming with Barrett's U2 minus 2.18. And that was pretty accurate when I went ahead with the surgery of this case. Also, there are other formulae like the Kane, the Olsen, which take into consideration that the ratio of the posterior segment of the eye is altered. So you have a larger vitreous cavity, and that too has a liquefied vitreous. So the refractive indices change, and these formula take that into consideration. But for the general ophthalmologist, always target myopia, maybe minus 0.5 or 1, and definitely beware of a hyperopic surprise. Obviously, because of the deep anterior chamber, the ELP may be different. So negative power IOL planning also needs to be done. Now, once you start the surgery, which I'll just elaborate, the deep chamber is a challenge. There is posterior capsular trampolining, that's the lidris thing. And I'll just demonstrate on the video where it's pretty evident. Also, the reverse pupillary block and the zonular laxity. Now, we all need to know that our surgical parameters for high myopes need to be different. So, the rhexis, because the things appear to be closer to you when you're doing your surgery. So, you might end up with a rhexis which is larger than what you anticipated or what you desired. So, rhexis should be spot on. Your gentle hydrodissection, your settings should be adequate for high myopes. So I'm using an IOP of 36, a vacuum out here it's more, but generally 300 to 400, and an AFR of about 25 to 30. Definitely a vertical chop works better because of the deep anterior chamber. The fluid expulse, as we all know, the IOP or the bottle height should be lowered. A very stable wound construction is a must here. See, if your wound is slightly leaky, the fluctuations which are already going on will be accentuated. Number two, if you have a long tunnel, number one, you will have overlocking and the stress on the cornea because your direction is towards the vitreous of the phaco handpiece. So you're going to have more striae on the cornea, so your visibility will be compromised. Obviously, the IOL of choice in such high myopes is a multi-piece lens because it fits into the bag very well, but you can have other options as you desire. The multi-piece lens has another feature, it has a very sharp optic edge, and that prevents PCO formation. And we all know that YAG in such cases may contribute to a retinal detachment. So RD risk is definitely higher it's higher in younger patients with high myopia. You need to counsel the patient regarding that, and obviously urgent referral in case it does occur. So these are just the summary of that. If we take the take-home pearls, number one is the formula optimization, and that is very important. Control of the fluidics, again, is of paramount importance, and you should have, number one, a pre-op retinal examination by your retina colleague, and also a retina person who will manage these cases, see these cases, let's say 4 to 6 weeks after surgery. So I'll just go on with my video. So as I said, the red glow is excellent in high myopes, but your rhexis tends to be larger than what you had aimed for. So the movement of the viscoelastic should be heavy. I prefer 1.4% sodium hyaluronate, and the movement should be towards the roof of the cornea so that you achieve 5 to 5.25 millimeter rhexis. Hydro procedure should be gentle because you know that the anterior chamber may fluctuate, and in these cases, later on you have a harder nucleus, but generally they present to you earlier. Phaco settings, just as I pointed out, the IOP should be low, AFR should be on the lower side, and the vacuum should not exceed 400 millimeters of mercury. So here again, the protocol is do slow motion phaco, do it very gently, and never allow, now you can see the fluctuations, and that lid risk also occurs because of that, where you can slightly nudge the iris and prevent it. Aspiration irrigation, I prefer the bimanual approach. This is my own devised Bhargav hydro implantation irrigator, which has a flow directed posteriorly, so it maintains the anterior chamber much better than the conventional irrigator which has a bidirectional flow. Meticulous cortical cleanup is necessary, and each fiber needs to be removed because you have to reduce the incidence of PCO in such cases. Here, my preference is a multi-piece lens, and as I just said, the cartridge has to be specific. You can use a B cartridge, which is a larger one, but I prefer the C one, and my incision size is 2.8 millimeters. We are all used to implanting single-piece lenses and rather one-piece lenses. Here, the configuration of the haptics is a little intimidating. So the basic rule that I follow is, first supinate your hand while you are inserting the lens, and once the optic is in, then pronate it so that the orientation of the haptics comes out very predictably. Secondly, dialing such cases is a little difficult because of these memory-oriented haptics. So better nudge the IOL into the capsular bag. So as you can see, the rhexis is well covering the IOL, and then I prefer the 3 and 9 o'clock position so that photopsias are minimized. Remove every morsel of viscoelastic because viscoelastic behind the lens might contribute to PCO and also a refractive surprise. So my take-home message, my experience, it basically boils down to three things. In high myopic cataract surgery, if we remember three things, we can have great results. Number one, plan carefully. Number two, control the fluidics. And number three, respect the retina. Thank you for your kind attention.
Any questions for Dr. Bhargav?
Beautiful technique, beautiful surgery on that.
Thank you.
When you have very myopic eyes, do you have a preference if you're going to do a primary piggyback IOL?
Okay, that depends on what the power you've calculated. Like this was the IOL power was -3, so it's available with Alcon. I think they go down to -6. I haven't operated any eye which had a power more than that, but definitely, like you say, a piggyback can be done if the eye. It's more common in hypermetropes, the piggyback thing. But in myopes, I have not done it. But yes, you have a valid point. Thank you.
I think piggyback is much easier and much safer in myopic eyes because you have a larger AC depth. So you can plan that.
Absolutely.
And about this three-piece Alcon you had to put because of the power. Rayner has hydrophobic IOLs which go up to -8 diopters.
Okay.
Those are one-piece IOLs. So that you can plan in case you don't want three-piece IOLs. So we can.
I think
take
Alcon goes up to -6, so
Alcon
that
so
is
only it is Rayner in the market which gives us hydrophobic IOLs which are up to -8 diopters. They are preloaded lenses, so we usually
And
use
in
them.
addition, I'd like to add, there's an Indian company, IOC, which can customize your lenses. Suppose you want you are operating a high myope where a toric lens is not available. So you can send them the parameters, they'll design that lens and send it to you so that you can have a better refractive outcome.
So what is your thought about CTR using high myope?
Yeah.
Because layers become bigger because the area is too big inside. So lens may
Correct.
become unstable. So
That is the reason why we don't have single piece lenses for these high numbers. But yes, if you feel that there is a zonular laxity, if you feel that the bag is a little more floppy, then I think a CTR would be a very good option to support your IOL, as well as, I don't know of the PCO rate incidence, how does it go down or not, but yes, it's definitely a beautiful option.
Anything about LIDRS you'd like to add, that how to tackle LIDRS?
Yeah.
One is that reverse.
That is, yes, absolutely, absolutely. That is such a common entity, your lens iris diaphragm retropulsion syndrome. Now, first thing that you will do is your IOP settings. You're going to have a low IOP. You're going to have a low AFR. If your AFR is less, the fluctuations will be less. Third is your incision, like I pointed out, it should be adequate. And if it's occurring, then what you can do, you can take a spatula and just go beneath the iris and just tent it upwards. So then the pressure normalizes and you can continue with your surgery.
We have an ongoing study at our center in which we are using replenishing the intracameral lignocaine again and again in these cases, and we have seen that the amount of IRDS is slightly LIDRS is slightly lower, and in fact in many cases not there.
Okay.
The hypothesis that we thought of after reading the literature is that these eyes usually have a lax, the eyes which go into LIDRS, they have lax zonules. Now what happens is when we enter, there is a, because in myopes there is a sudden deepening of the anterior chamber, there is more pain on the zonules, there is stretching on the zonules, and that causes further ciliary body contraction. So if directly injecting lignocaine and again on the ciliary muscles, that will not cause their contraction. So only thing we are left out with the lax zonules. So that decreases the incidence of LIDRS.
That's a great point, and that just goes to say that LIDRS is not only mechanical. it is
So
chemical also.
this paper we had presented in ASCRS last year. Any other questions? So if we don't have any further question, I invite upon our next speaker, Dr. Tanveer Alam Khan. He'll be speaking on phaco in high hypermetropic eyes.
Very good morning to all. I'll be talking about phacoemulsification in high hyperopic eyes. So phacoemulsification is the gold standard of cataract surgery worldwide. However, performing phacoemulsification in high hyperopic eyes is particularly challenging because it is associated with a higher rate of intraoperative and postoperative complications and a poor postoperative refractive predictability. So coming to the preoperative challenges, comparing the best corrected visual acuity, refractive error and degree of cataract is very valuable for surgical planning. Specifically, if there is a significant difference in visual acuity bilaterally in the presence of a similar degree of cataract, or if there is a large degree of anisometropia, one has to consider the possibility of amblyopia. This becomes important because this assessment helps to identify pre-existing amblyopia, which is very common in hyperopic patients, and you can manage the patient's expectations for visual recovery after surgery, and also you can plan whether to put a premium IOL or not. Another preoperative challenge is in the presence of a shallow anterior chamber, it is necessary to check IOP, AC depth, peripheral anterior synecdoche, posterior synecdoche and anterior segment dysgenesis. In such cases, gonioscopy, ASOCT and ultrasound biomicroscopy should be considered. And if the angle is occludable, a peripheral iridotomy should be done first. Also, there are studies suggesting that Fuchs dystrophy is more common in shallow AC eyes. So if you have availability, a specular microscopy can also be done, or a careful specular examination should be done to rule out Fuchs dystrophy. Another thing is that high hyperopic eyes usually have increased scleral thickness, which in turn increases the risk for uveal effusions. So ASOCT and UBM are useful in determining scleral thickness and to exclude any subtle uveal effusions in the preoperative period. These pre-existing effusions should be treated preoperatively with cycloplegics or steroids, or even creating scleral windows several weeks before the cataract surgery. Then there are challenges in IOL power calculation also. Short eyes are more prone to errors in axial length and effective lens position measurement. Therefore, post-operative refractive surprises are more common. So the most accurate methods of obtaining AL are the optical biometers if you have availability, like the IOL Master and the Lens Star. And coming to IOL formulas, the best formulas for such eyes would be those that can most accurately predict the ELP. Various studies have found that for eyes less than axial length of 21.5, Hofer Q is the most accurate formula. But now recent studies have shown that newer formulas like Kane formula, Hagee's formula, Holiday 2 formula and Barrett's 2 formula are as good as Hofer Q for the short eyes. Coming to the intraoperative challenges, first thing is surgical position. Since small eyes are usually deep seated, a temporal approach is preferred because it will ease the instrument maneuvering rather than a superior position. Shallow anterior chamber is another thing which happens in hypermetropic eyes. So these eyes have short axial lengths which and also have crowded and shallow anterior chambers. So there are several risks associated with shallow AC. Increased risk of endothelial damage, difficult maneuvering of instruments, and increased risk of posterior capsular rupture. Okay, so in paracentesis, you have to, while making paracentesis, aim the blade slightly horizontal to avoid hitting the anterior lens capsule. But also don't make an excessive long tunnel, because that excessive long tunnel will make the instrument maneuvering more difficult. So you have to balance the two things. Always use a high density cohesive viscoelastic optimum amount to deepen the AC, And you should avoid overinflation of AC because it will lead to iris prolapse. Coming to main wound creation, the main wound must not be too short or too posterior. Aim for a 2 millimeter wound, a triplanar wound. Both these things, too short wound or too posterior wound, will increase the risk of iris prolapse. So aim for a 2 millimeter triplanar or biplanar wound. Coming to capsulorhexis, in small eyes, shallow anterior chamber and forward lens vault will make the capsulorhexis more prone to run out. So perform the capsulorhexis slowly and carefully, and also use a cohesive viscoelastic to flatten the anterior lens capsule. You can also prefer to do the capsulorhexis from the side port in such cases rather than the main port, so that the OVD doesn't egress out and the AC is maintained. Also, it is important to protect the endothelium during phacoemulsification because these eyes have shallow AC. So use a dispersive viscoelastic like Viscoat just before initiating phacoemulsification, and you can replenish it also to protect the endothelium. Hydrodissection step, small eyes will have a high risk of iris prolapse, so hydrodissection should be done gently with a minimal fluid in such cases. Another challenge is poor pupillary dilatation because the small eyes often have a poor pupil dilatation. So these, as these eyes will also have a shallow and crowded AC, so iris hooks are a better option than pupil expansion rings because you will not have enough space in the AC to manipulate the pupil expansion devices like Malugan ring and other rings. Positive vitreous pressure is another problem with hyperopic eyes, which can lead to chamber collapse during surgery, iris prolapse, lens instability, or difficulty in maintaining a deep, stable chamber. So to counter the positive vitreous pressure, pre-op use of mannitol is advisable. It dehydrates the vitreous, thereby reducing the positive vitreous pressure. And if the posterior pressure is not reduced with mannitol, a vitreous tap can also be done using a trocar cannula or a simple 26 gauge needle. Uveal effusions are another risk in hyperopic eyes because these eyes have thick sclera which impedes the fluid outflow and leading to a higher risk of choroidal effusions. So to prevent uveal effusions, previous literature suggested creating scleral windows at the beginning of surgery. However, this strategy is risky, not recommended now because it will weaken the sclera and already there is a positive vitreous pressure, so there can be perforations. So, but however, if uveal effusions develop during phacoemulsification, the surgeon can create inferior sclerectomies to lower the IOP and complete the procedure if he is comfortable, or he can simply close all the wounds and complete the case later on once the choroidal effusions settle down with steroids and cycloplegics. Okay, so in eyes who are prone to uveal effusion, chamber stability is very crucial during phacoemulsification. After nucleus management, you should inject viscoelastic before removing the phaco handpiece, as we do in PC rent cases. Prehydrate the wounds before switching to irrigation aspiration so that iris prolapse doesn't occur. Viscoelastic should be injected again before removing the IA handpiece. So the chamber stability should be maintained to minimize the risk of uveal effusions. And wound closure, hydration of main wound should be performed slowly and carefully to avoid any iris prolapse. Do not overhydrate the wound, and if needed, it is advisable to put a Tanjiro nylon suture if the wound is not closing. There are several post-op complications more common in hyperopic eyes, such as corneal endothelial damage, DMD, cystoid macular edema, uveal effusion, angle closure glaucoma, and aqueous misdirection syndrome. So this is a surgical video of a hyperopic eye. So the paracentesis is made slightly horizontal to avoid touching the anterior lens capsule. Then I am injecting a high density cohesive viscoelastic to deepen the AC. Performing the capsulorhexis from the side port very slowly and carefully while maintaining a deep AC. Main wound is created, a 2 mm long triplanar wound is created. Then visco is removed, and hydrodissection is done gently with minimal fluid. Nucleus is rotated after hydrodissection. Then a viscodispersive OVD is used to coat the endothelium to protect the endothelium. Then phacoemulsification is done as routine. I prefer the direct chop technique. After phacoemulsification, before removing the phacoprobe, I inject viscoelastic from the side port to maintain the AC and to avoid fluctuations. Then prehydrate the wound little bit. Then use IA probe to remove the cortex. Again inject viscoelastic from the side port to maintain the AC. Then IOL is injected. Viscoelastic is removed from behind and ahead of the IOL. And finally, wounds are closed with hydration, with a gentle hydration. Okay, this finishes the case. So my take-home message would be high hypermetropic eyes present unique challenges and risks during phacoemulsification, such as shallow AC, positive vitreous pressure, and uveal effusions. A modified approach to phacoemulsification is the key to success in these eyes. Thank you.
Thank you, Dr. Tanveer. Any questions from the audience on high hypermetropic eyes? We have Dr. Vishali with us, who is a prolific surgeon from Jaipur and a great academician. I'll request her to give her insights in high hypermetropic eyes, what challenges she has faced and how she has taken care of those.
Sir, I think this is a very relevant topic and you really amply covered all the points. But the main thing is, as you very rightly showed, preparing and knowing. So I think it's very important that just before we go, we should not be seeing the IOL powers on the day of OT on your chart. So previous day we all should be preparing and looking at the axial length, the AC depth and the IOL power, all three, so that you know. So I think preparing is very important because it also helps in counseling the patients that you are an off the normal or an off the standard eye. So you might end up with a little more than what we targeted, more or less. So we cannot 100% target. Plus, I think in terms of formulae, you very rightly said that we all learned that offer Q is the best for short eyes. Now I think it's with the newer formulae, my personal preference is the Barrett group of formulae. And also the Kane and Evo, which are, the Kane also is an AI based formula in parts. These are also coming up very, very good. So I think that is what is needed. And one last thing I like to say is in these thick lenses, be very careful of your incision size when implanting. So if you are normally doing a 2.2, if my IOL is 25 diopters or above, I will do a 2.4 incision, so that I don't want to do, it's a thick lens, so particularly hydrophobic lenses. So I would enlarge it a shade more and make my implantation more smooth. Thank you, sir.
Thank you, ma'am.
2 points that Dr. Tanveer has taken out very rightly is that there is an increased chance of Descemet's detachment in these eyes, and second is uveal effusion. So uveal effusion, as he injected viscoelastic before taking out the phaco handpiece, is very important. We should not allow the chamber to prolapse, especially if the patient is having any sort of cuff reflex on the table. Because during my period of 35 years doing all these surgeries, what I have faced is, if such a patient is having any cuff reflex, the chamber will become flat. Then you can't do anything after that. The best thing is to close your wounds, wait for next day and then operate the next day. So always keep the chamber inflated if you want to avoid this particular complication of uveal effusion. About Descemet's detachment, can you highlight slightly more than, like you said, that the side port incision that you rightly said should not be too long, because then your chopper can create problems. So, while you are doing phaco, do you advise that every time we inject viscoelastic first and then inject the phaco probe?
Yes, sir.
Because that
Yes.
will again help us
Yes,
in
yes. Never enter directly
avoiding
with the
this
fluid on.
particular-
Yes.
Also, sir, the side port can be made much better with an MVR knife. Because you have a small eye and crowded area. So an MVR, 21 gauge MVR would be more
better than the 15-degree blade. Yes, sir. Yes. True.
So in all these eyes, preoperative planning and peroperative planning, what instruments you have in your OT, so that is also very important, and how you go about it, the viscoelastic that you use. I think if we don't have any further questions, we come to end of this instruction course. Thank you everyone for attending this.
Thank you, sir.
Once again, welcome to Rajasthan, to the pink city of Pink City and Holy Rajasthan. Thank you. So to be seated, because this is going to be of great help to us, this keynote address.
Thank you, Dr. Kunger. Thank you to the organizers. I'm very excited to be here with you today to discuss contemporary full visual range IOLs. Here are my financial disclosures. So today we're going to talk about the timeline of contemporary full visual range IOLs in Canada. We're going to talk about the science behind these IOL designs. We'll talk about outcomes from clinical trials and how these may differ from past intraocular lenses. We're going to talk also about who we might recommend these lenses to. So if you want to have happier patients, sleep better at night, and make more money, listen up. In 2016, we got the fine vision intraocular lens. This defined new trifocals. This gave us true full range of vision. This was followed by PanOptix, which quickly became the market leader. Zeiss came out with the AT Lisa, and then we came out with the fine vision toric and Ray 1 trifocal in 2021. Contemporary full visual range IOLs started in 2024 with Envista Envy. In 2025, we got Tecnis Odyssey by Johnson & Johnson and PanOptix Pro just a few weeks ago from Alcon. One of the major factors preventing surgeons from offering more premium IOLs in their practice in this recent survey was a patient's inability to cope with glare and halos. Envista Envy was designed, it was diffractive, with apodized with smooth edges. It has an aspheric posterior surface, and all rings are under 1 micron in height. Tecnis Odyssey uses digital optimization. They use AI in the design of the lens. They use custom echelettes that are 50% smaller in step heights to provide more precise light control, and this was supposed to minimize dysphotopsias. PanOptix Pro used precise and targeted small changes in the diffractive structure with under a 0.5 micron step changes. This was supposed to maintain the benefits of PanOptix but recapture light. They have 94% light utilization with the new design. I led the Canadian clinical trial, the first in the world on Envista Envy, and we're going to discuss some of the outcomes from that trial. This was published in the Journal of Cataract and Refractive Surgery. This was a prospective multi-center active controlled binocular study on Envista Envy compared to the monofocal IOL. We enrolled our first subjects just prior to the pandemic really breaking out and last in June of 2022. As I mentioned, there were 9 sites and 9 investigators. We had 172 subjects that were randomized. I borrowed this from the US clinical trial because this is what you'll see in the marketing materials. Best directed distance visual acuity binocular 2020, intermediate 2025, and near 2025. So if you're looking at this, you look like me, you think 2025 isn't 2020. 2025 is what was achieved in the FDA clinical trial for PanOptix. 2023 was achieved by Synergy with Odyssey that has supplanted Synergy. They also got 2025 in their real world study. So the range is not better. These were not designed to improve upon the range that we already had. It was designed to reduce side effects. So looking at dysphotopsias, this is the quality of vision questionnaire. When you're asked or you're presented with data from a company and they say, here's the dysphotopsia data, the first question that we should ask is, was this a directed questionnaire or non-directed? If it's non-directed, they just ask patients, do you have any problems with your vision? And if the patient doesn't say starburst, they don't record it as such. No patients have the word starburst in their vernacular, so this leads to underreporting. In clinical trials such as this, we use the QOV, which is an open source questionnaire. Patients are shown, this is a glare, this is a halo, this is a starburst. Do you experience them? How bad are they? Okay, this is designed to try to make patients report it. In the clinical trial in Envy, halos, there was a statistically significant difference seen in the frequency and severity of halos, but there was no statistically significant difference in the rate of patients that had bothersomeness to halos, so reporting not at all or a little bothersomeness to halos. In terms of glares, the frequency, severity, and bothersomeness of glare was not statistically significantly different between full visual range and monofocal IOL groups. Looking at starbursts, a statistically significant difference was seen in the severity of starbursts between full visual range and monofocal groups, but the frequency and bothersomeness of starbursts was not statistically significantly different. In European Society in Copenhagen in the fall, we pooled together data from the US and Canadian clinical trial and looked at residual cylinder. So does increasing residual refractive cylinder mean that they'll be more likely to have bothersome dysphotopsias? When we looked at glare and we looked at halos and performed logistic regression analysis, we found that there was no correlation between increasing refractive cylinder and dysphotopsias. None of us are perfect, and with this lens you don't have to be, because it has some built-in tolerance to residual cylinder. Looking, unsurprisingly, the full visual range IOL massively outperformed in satisfaction with near vision and spectacle independence. This is from Caribbean Eye Meeting. We presented this last month. This is from the real world study. So we're collecting data after post-market. And as you can see, only 2.1% of patients reported any dysphotopsia with Envista Envy. This is because this is a non-directed questionnaire. It's underreported, but patients in the real world really don't complain of these things. So there's a built-in feature to Envista Envy that's little known. This is the focus curve. You can see this is Envista Envy in the blue and Envista Monofocal in the orange. Higher is better. This is the distance portion of the curve. This is the intermediate. This is the near portion. When we look at small pupil size, you can see from the overall data to the small pupil size, the curves are basically the same. If we go to medium pupil size between 3 and 4 millimeters, you can see again almost no change in the curves. Now we're going to go to mesopic. This is the hardest circumstance for any diffractive presbyopia correcting lens. You're going to see the curve drops, but importantly, you're going to see that the curve largely drops at intermediate. This was a design decision made by the engineers because what are we doing in intermediate? Our patients are looking at their phones, they're looking at their tablets, they're looking at their computers. These are all backlit. They require less light. So what they decided to do was put more light to distance and more light to near under mesopic conditions. So what does this mean? Patients complaining of problems with night driving. Patients complaining about reading a menu in a dimly lit restaurant. That's less likely to happen. We found 84.3% of patients said they had no problems or little to no trouble reading up close in dim lighting. Okay? Contrast sensitivity, critical. As you can see, there was no statistically significant difference, but you can see Envista Envy in green and Envista Monofocal in blue. If we had more patients and higher power, of course there would be a difference in contrast sensitivity. Nobody expects a diffractive lens to be exactly the same. However, it's a slight difference. So how does this differ from past intraocular lenses? We have very low rates of bothersome dysphotopsias for the first time and excellent defocus curve performance as we've come to expect from trifocals. 90% of patients reporting little to no difficulty completing activity spectacle free. This is the global first commercial implantation of Envista Envy. I'd performed this in Calgary. This was different from the prototype that we used in the study, just very slightly, and a difference in the material. As you can see, as I'm injecting it here, you're going to see it unfold very rapidly, as common with the Envista platform. What you're going to notice is the echolets are all very low, and they have smooth edges. This is probably why the dysphotopsias are so long, in addition to being a continuous full visual range. If the patient looks slightly off axis, if you're not careful looking at the slit lamp, you can't see these echolets at times. You'll have your optometrist and your referring doctors tricked actually by this because it's not as obvious as with past diffractive lenses. This patient on the first day was 20/20 in the distance, no glares, halos, or starbursts, and reported full visual range. I performed the first Technis Odyssey in Canada last year in May of 2025. They also report very low rates of dysphotopsia. So 93% at 1 month reported mild halos or glare or less. So in terms of distance contrast, Technis Odyssey, lab bench data, outperforms a competitor's monofocal in distance contrast in mesopic conditions. Okay, this has to do with the spherical aberration correction and the low amount of chromatic dispersion on this platform. PanOptix Pro, recent entrant into the market. You can see that this shows the number of patients that preferred it for starburst and halos in the purple to Clarion PanOptix. So who should have these intraocular lenses? So I used to do a personality inventory. Are you a perfectionist? Would your friends describe you as such? Are you a type A personality? We used to think maybe those people shouldn't have it. For me, hunters we used to worry about. Professional drivers, I no longer worry about that. Why did I put family members of ophthalmologists and ophthalmologists themselves? If you remember going to any of the meetings about 10 years ago when the past lenses were on the market, you'd go and you'd hear all of these ophthalmologists talk about these amazing new diffractive technologies, and you ask them at the end, what lens would you get yourself? And nobody would pick the diffractive multifocal lens. So when I was a resident, I decided that I was never going to implant these lenses without telling a patient, I wouldn't get this in my own eye, I wouldn't give it to a family member. You can choose it if you want, some people will still benefit from it, but I needed you to hear that before you pick it. Now, I can tell you for sure myself, if I had surgery today, I would be getting a contemporary full visual range, intraocular lens in both eyes. I'm now confident to recommend it to patients. In terms of targeting, Envista Envy should be plano to first plus, Technis Odyssey, plano to first minus. And PanOptix Pro is still plano to first plus. So here's the Barrett Universal 2 formula for a real patient. On the right eye, you can see that I would pick for all three of these lenses. The closest to plano, that's plus 0.04 as a result. For the left eye, I'd put Odyssey at the minus 0.17. I'd put Envy and PanOptix Pro at the hyperopic result. We're presenting this study at Askers this spring. This was eyes with residual sphere of plus a quarter with Envista Envy were the most likely to achieve uncorrected distance visual acuity 20/25 or better. We were all taught 10 years ago that we should be leaving residual myopia. You want to take the first minus. Do not be afraid of plano. Do not be afraid of first plus. Contemporary full visual range IOLs are a dramatic improvement on what we used to have. Patients have a high rate of spectral independence with bothersomeness. So the frequency and severity is higher, but the bothersomeness to dysphotopsias was not statistically significantly different from monofocal controls between months 4 and 6. That's when we checked it. This expands the number of patients for whom these technologies can and should be offered. I think we're doing our patients a disservice if we're not using them now. And if you were scared away from the table of full visual range IOLs in the past like I was, now's the time to come back. Thank you.
Thank you. Very nice talk. I'd just like to ask you one question. What is the central ring size in this lens?
I have it right at the beginning. Let me go see if I actually had it written down there.
Because what I'm seeing from the slides, it shows what I personally like. I'm just my subjective observation. The central ring is slightly larger than the other lenses.
Yes, yep, that is actually true. So 1.2 millimeter central zone. Okay. Yeah.
Just for the audience, as he rightly said, that we have recently Technis Odyssey, which was not available in our country till now. Just last month we have got it in our country, and it is on the same platform as Technis Synergy, but the company claims that it has only 3% of glare and halos of what we get in Technis Synergy, because they have decreased the step height and the sharpness of the step height has been rounded off. So these two modifications they have done. Can you put some more insight into Odyssey, because we have recently got Odyssey in our country?
Sorry, can we do which, sorry?
Technis Odyssey.
We have Technis, yes, and the Technis Odyssey, is that the lens that you guys just got? Because the Technis Odyssey, if you're used to Synergy, that used to get a lot of glare, halos, and starburst if you had any defocus. Technis Odyssey does not have that same problem. Technis Odyssey is a fantastic lens, absolutely outstanding. We've been using it a lot, and those results that I showed where it was 93% of patients, little to no bothersomeness, that's at 1 month. So we used to think with the old full visual range lenses, you'd put it in and at 1 month the patient would be kind of unhappy with their glares and halos, but they had really good vision, they'd be happy with the range, and you'd be like, ooh, this is a really good early result. I think 4 or 5 months from now you're going to be happy. What the new lenses do is patients are happy early. A lot of them don't get the dysphotopsias at all, and then if they do, they're very mild. So patients, you no longer have to get them over that hump. You no longer have to worry, are they going to be able to tolerate this and be hemming and hawing if you should take it out. So if you have Technis Odyssey, it's available to you now. I strongly encourage you to use it. I use that lens all the time. The other thing is if you have a past lens that's in one eye, I do a lot of mix and match. I do a lot of lenses that it's blended vision, so we'll do it with an extended depth of focus lens. I'm not sure if you have Technis Pure C, which is unbelievable, and it's extended depth of focus lens, same contrast as a monofocal. Don't be afraid of giving them the new version in one eye and the older version in another eye. Patients tend to blend those very well. I always warn them, this is off-label. You may not be able to do it. I've never had to explant for that ever.
One last question. I know we are slightly overshooting our time. Would you recommend using these eyes in moderate dry eyes also?
So dry eye, it was an excellent paper by Steve Schallhorn. I think it was like 40,000 eyes. And they talk about, what are predictors for patient dissatisfaction? And dry eye is a major predictor of dissatisfaction following cataract surgery, particularly with presbyopia correcting lenses. So you definitely want to manage dry eye maximally. Things that were not found to be predictors that people used to think about. So large pupil size. There's studies coming out showing that pupil size is not a predictor of patient dissatisfaction, even though we thought that it would be for obvious reasons. Angle kappa, large paper in Journal of Refractive Surgery by Avi Wallerstein, one of my colleagues. It was like 27,000 eyes. They showed that angle kappa, so you used to worry if the lens isn't going to line up right on the in the pupillary axis, on the patient's visual axis, that patients might be unhappy. Again, not a predictor, okay? And so all of these things, what I've learned with these new lenses is all these things that we thought maybe would be a predictor of dissatisfaction. I just showed a case at the European Society winter meeting of inferior steepening, so ectasia suspect with Envista Envy, patients super happy. So don't be afraid of explanting a lens. I always talk to all these patients with these little abnormalities and say maybe we have to explant. more often than not, we're not. Okay, it's very uncommon to do so.
Thank you. With this, we end our IC, and I like to have a group photograph first, and then we hand over the hall to the next panel.